Okay, this is going to be physical exam and secondary assessment. This is going to be chapter 16. After completion of this chapter, you will be able to understand the four components of each physical exam, when a focused history physical exam should be conducted on the scene or a rapid physical exam is appropriate, detailed physical examination and its appropriate use, matching the proper physical assessment with the patient's presentation or chief complaint, and the ongoing assessment as a repeat of the initial assessment and used to detect trends. Now, trending is kind of something that we look for, that we have the ability to kind of see if something's headed in the right direction. Example of this, someone's having decreased lung sounds and shortness of breath, and their SATs from baseline start dropping. Well, that would be trending towards I have some kind of respiratory compromise. So really assess at that point better the lungs and the lung sounds to see if we can spot a developing tension pneumothorax. Physical examination. Assessment of the patient from head to toe helps the paramedic detect chief concerns or chief complaints. May detect signs of presence but unrelated conditions. So in this assessment you may find other things, but it may not have anything to do with the primary complaint. Helps determine a treatment plan, and that's because you find clinical findings in this. Important when history is not obtainable is that you find empirical evidence to base your treatment plans on. Physical exam techniques continued here. We're going to do a specific amount of things, and that would be these over here. And we're going to do inspection, auscultation, palpation, percussion, and vital signs. Now, what inspection is it's pretty much looking at what the problem might be. And auscultation would be listening with your stethoscope. Bowel sounds, lung sounds would be an example of this, or upper airway stridor. Palpation would be actually hands-on assessment, so feeling bony structures, crepitus, and things like that. Percussion is kind of an art. Percussion is used, an example of percussion would be you put a finger in the middle of their ribs and you tap on it. Well, their lungs, when filled with air, should sound hollow, so it should be kind of a deep sound, where if it was filled with blood in that section, it would sound solid, which would be like a more of a dull thud. So these are figure 16.3, auscultation using the diaphragm and auscultation using the bell. And this over here is palpation of the abdomen. This here would be palpation of the chest cavity. So the only way that you're going to see, like say if this guy had a flail chest segment, is to either one, see it and look at it, or two, to feel it, the paradoxical movement. This is going to be figure 16.5, and this is percussion. And what percussion allows us to do is to hear if something is solid or hollow. So by tapping on this, if it sounded hollow underneath here, this would be in the lung section. So this entire area here would sound hollow if filled with air. Now if it was filled with blood, it would sound more like a solid organ or sound like a duller thud. Vital sign measurement. And vital signs include several things: pulse and respirations, and this kind of gives us a hemodynamic status of the patient. How fast is their pulse? How fast are their respirations? Their blood pressure, their temperature, whether they are febrile or afebrile, or with or without fever, skin condition and color. Now, if they're in shock, in the skin condition, they'll actually become diaphoretic and start shunting towards the core. And then if there are any pain, 10 scales are always awesome. Scale of 1 to 10, 10 being the worst pain you ever felt in your life. What would you say this pain is to you right now? Pulse oximetry and capnography, and then orthostatic vital signs. Now, very simply, if you raise somebody up and they have a near syncopal episode, they are tilt positive. You do not have to continue with the orthostatics. But laying someone flat to having them essentially sit up to having them stand up, if there's more than a 20 beat per minute increase in their blood pressure in this time frame, then they are tilt positive. These are normal respiration values on table 16.2. And if we'll notice, toddler preschoolers 20 to 30, school age 6 to 10, 15 to 30, adolescent 12 to 20, and then middle or adult age 12 to 20. And this right here kind of depends on the patient's health. They could be very rapidly breathing or not rapidly breathing. If they're over 65, their actual ailment itself could impose a problem with this. Infant to, I kind of did these in reverse, but infant to birth to 1 year of age, 40 to 60 respiration, and then it drops to 30 to 40 after a few minutes and slows to about 20 to 30 by the first year. These are 16.7 common pulse points of the body. Please look over those: temporal, carotid, apical, which is done with the stethoscope, 4th or 5th intercostal space, midclavicular line, brachial, radial, femoral, popliteal, posterior tibial, dorsal pedalis. Be sure you're aware of all of those pulse sites. This should be a review from EMT Basic. Figure 16.3, proper placement of the cuff. Be sure you're on the inside of the arm. Always a good spot. I know that seems pretty self-explanatory, but something that y'all can see here. Be sure that you're on the inside of the arm. You can probably hear it better. And this is the process of respiration. So at this point, oxygen comes in, goes to the alveolar sacs, higher content of oxygen transferred to the hemoglobin. Hemoglobin transports it to the cells. Oxygen's offloaded. CO2 is picked up, gets transported back. CO2 then comes out in the alveoli, and the oxygen reloads the hemoglobin molecule. It happens all over again. Assistance begins with the chief concern or complaint, and there's several different matrices here we need to talk about. One of them being a focus matrix, and very simply, a focus matrix is the patient complains about something, and we look into their complaint. So they're conscious, they're talking to us, they very easily can tell us what's wrong, and it's nice and clear and concise. So we are looking at that system and several other systems that might have caused that symptomology to try to figure out what clinical indications we have before we initiate treatment. The examine matrix, we can do several things here. Now, an examination, very simply, whenever we're looking at the ABCs, we look at airway, breathing, and circulation, and then after that, if they're not so forthcoming with the information, if they are unresponsive, and we are trying to detect if they have any life-threatening ailments, we should probably do a rapid trauma. Now, rapid trauma is essentially a head-to-toe looking for life-threatening problems. DCAP BTLS is an acronym to remember that by. Very simply go through there and see if you can find any problems with their chest or abdomen, if they got a hot abdomen, if their pelvis is unstable, even in a medical call. If the patient is not so forthcoming with information or they cannot tell us what's wrong with them, we should still do a rapid trauma or a rapid secondary assessment. Now that's like saying potato, potato. So as long as we do a systematic approach, and the systematic approach is kind of head to toe, and any of the ABCs that we find that are a problem with that, if they're having an airway problem or they can't breathe on their own or they have a circulation problem, we need to try to correct those immediately. And then a general exam. Now, a general exam, the easiest way to do that is to start at the head and work your way to the toes. So, there's several pictures here and just some things to think about as we kind of start talking about them. Chest pain, figure 16.27. Now, in your book, very simply, the question you should ask yourself, what all could cause chest pain? And we can get the cardiovascular system involved in that. We can get the respiratory system. There can be gastrointestinal problems, neurological problems. So all of these assessments we should probably pretty much do to differentiate any kind of signs and symptoms that we might actually see. Altered mental status, if they have that with this, be sure that the brain is being perfused by the cardiac system. Shortness of breath. Start off with the respiratory side, involve the cardiovascular and the neurovascular. Determine their level of consciousness, and if they're in any respiratory distress, how much energy are they using to breathe, things like that. Abdominal pain, and this is just general overall view of assessment. You should do this by systems, and in the skills videos we'll elaborate on that even more. Assessment of the patient with a chief complaint of abdominal pain is what we have a picture up here. So take a look at their gastrointestinal side, take a look at their cardiovascular, and then try to determine. The thing about the abdomen is that it can give us diffuse pain. So whenever we're looking at the overall abdomen, there's lots of organs in there. They can refer pain to other locations depending on which organ is inflicted. Syncope is a wolf in sheep's clothing. There are multiple causes of this. This is fainting, essentially. Was there any neurological concerns? This could be as grave as I've developed a new tumor in my head, to I had a run of VTAC, and that's why I had an altered LOC. If there's any kind of musculoskeletal weakness as well, it could be stroke in origin or neurological issues. So please go through a systematic approach and take a look at these. But general good places to start on syncope would be, like I said, their mental status, cardiovascular, respiratory. See if you can actually find a cause for their syncope. Altered mental status and syncope are like potato, but this one expands a little bit more. Neurological, cardiovascular, respiratory, skin. This could be psychiatric. This could be drug related. So look at your patient overall and see what got you there. If altered mental status is it, need to go through the entire gambit of assessment tools that you have. Extremity pain, this is going to be more focused. An example of this would, my wrist hurts. Well, let me take a look at your wrist. Take a look at their musculoskeletal system, take a look at their skin. It could hurt because they got bit by a spider. Cardiovascular system, if the person was having left arm pain, it could actually be their heart because of referred pain. Neurological status, did they have good pulse movement and sensation distal? High blood pressure, there's cardiovascular concerns. Do an examination that focuses on detecting any signs of heart failure in the respiratory side. If they have any increased respiratory effort. Neurological, if they have any kind of deficits, please note those and try to get ahead of that pathology as quick as possible. Head, ears, eyes, nose, and throat. Whenever we assess that, we assess the head for trauma, the eyes for redness and swelling, ears, nose, throat, any kind of alterations of what we would consider normal. Fever, assessment of the patient with a chief concern of fever. My biggest concern is that they have some sort of bacteria growing in them. Now, the quicker that we get ahead of the bacteria's proliferation and get them an antibiotic, probably off the better that they will be. Sepsis is also a concern as well, so I need to pay close attention to my patient's hemodynamics. Pregnancy. If there's any gynecological concerns, if they've had, very frankly and very nicely and professionally, ask them if they've had any kind of STDs or gynecological problems. Ask them if this is their first child, or if this is number 2, 3, 4. How many living children do they have? We can palpate the actual the fundus at the top of the abdomen, so we can actually tell very easily if they're having contractions or not. Look for bursting of the actual amniotic sac. If their water is already busted, birth is probably pretty close. How frequent their actual contractions are, things like this. Again, as we get to these sections, we'll emphasize more on what questions to ask, what information I get back from those questions, and how to interact with the patient better. Trauma. Trauma should be head to toe when we inspect the head, the neck. We're essentially looking for anything that is busted, broken, or non-functioning properly. So head, neck, trunk, abdomen, pelvis, and extremities. In conclusion, these common chief complaints will cover the majority of the patients that the paramedic will encounter. There will be some patients that do not have one of these chief concerns. By using the principles to perform a physical assessment, a paramedic can perform a full patient assessment efficiently. And we are going to essentially start at the head and work our way to the toes. Please look at the associated skill video with this over patient assessment trauma. References for this chapter were taken from Richard Beebe, Professional Paramedic, Volume 1, Foundations of Paramedic Care, First Edition, pages 256 through 309 of Del Mar Learning. And if you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smithr@imsa.net, or 405-219-7613. Thank you.